This is my first time doing one of the echoes. I looked for the CMEs. It said you had to check in. I'm not really sure what that means.
Yes, I can get you an account created.
Yes, I did create one on the Highlands website.
Okay, yeah. I'll just check you in, and then after the session, you'll receive an email. I can actually take this off now. I'm sorry, I've been working with like 2 other programs at one time. But once you receive that email afterwards, it'll walk you through completing that evaluation.
Okay. And I
And
think I'm listed as Cynthia Adams, probably.
I'll write that down. And do you need nursing, AMA, or which credit?
The ANCC, is
Okay.
any of it work for that?
Mhm.
Okay.
Yeah, we have nursing. The College of Nursing actually grants that for us as well. So.
Okay, great. Thank you.
Rebecca, can you see the right screen?
Yes.
Okay, good. We tested this again yesterday, so hopefully it will be okay.
Okay.
Hello, everyone. It's Joyce Troxler. I'm here to facilitate your next I Am Echo session. It is a joy having all of you with us. And as we normally do, we'll go around and get everyone introduced. And then we'll have a didactic presentation. I've got this. There we go, a little bit better. I'll give the didactic today, and then we'll have a chance to answer any questions about that. And then we'll have a case presentation brought to us today by Veronica, who's sitting here behind me in the room. Yep. So we'll just go ahead and start with introductions. And since I've got to pass all of us in the room right now, I'm going to start here in the room. Since I already started with myself, Joyce Troxler, your facilitator, board certified in addiction medicine and family medicine. And then to go around the room that I am in.
I'm Veronica Van Ray, and I'm the bachelor's level social worker and certified peer recovery specialist.
I'm Caleb Osborne. I'm one of the fellows here in education.
Dr. David Imran. I'm one of the Kingsport residents.
And I'm Dr. Owens. I'm another addiction medicine fellow.
Thank you, guys. They're making me have to toggle the camera. I don't know if they don't want to get close or something. I don't know. So we're spread about in our room, probably as we should be with COVID precautions, et cetera, et cetera. Rebecca, if you can unmute and introduce, please.
Hi, I'm Rebecca Mahar. I am the ECHO coordinator.
Fabulous. Thank you, Rebecca. Meredith, if you can unmute and introduce, please.
Hi, my name is Meredith Finley. I'm an assistant professor in the Department of Psychology at ETSU and a licensed clinical psychologist.
Thank you, Meredith. Michael, if you can unmute and introduce.
I'm Michael Mishka. I'm a psychologist and a clinical director for behavioral health operations at TenCare.
Great. Thank you, Michael. Cameron, your turn.
Cameron Heil, I'm a psychiatrist, addictionologist, associate professor in ETSU.
Fabulous. Thank you, Cameron. David, if you can unmute and introduce.
I'm David Rohn. I'm a professor in the Department of Pharmaceutical Sciences in the Gatton College of Pharmacy at ETSU.
Great. Thank you, David. I Am Echo, also known as Melissa Hood. If you can unmute and introduce, please.
Hi, I'm Melissa Hood. I'm the educational planner for this program. And I will just take a second just to remind you all to complete your evaluation because it does help us plan for our upcoming sessions. So if you need any help with that, there'll be an email afterwards. If you need any help with that, just let me know.
Great. Thank you, Melissa. Those evaluations are incredibly important to us. So even if you just say, yeah, it was awesome and lovely, which you can totally do that, put whatever you want, be honest. But especially what we like is the narrative part where you sort of say like, I really enjoyed this out of this one, or I'd like to hear more about this type of subject or this other type of subject, whatever. That kind of feedback really helps us build our next year's sessions. Rachel, if you can unmute and introduce, please.
Hello, I am a clinical psychology doctoral student and I work up at Mountain City Extended Hours Healthcare Clinic.
Awesome. It's a joy having you with us, Rachel. Thank you. Cindy, if you can unmute and introduce, please.
Hi, I'm Cindy Adams. I'm a nursing instructor at UT Knoxville, and I just completed my postmaster's as Psych NP.
Awesome, congratulations. And thank you for joining us. Brooke, if you can unmute and introduce, please.
Hey guys, I'm Brooke Claiborne. I'm the behavioral health MAT and SUD case manager, as well as an addiction grad student.
Wonderful. Thank you, Brooke. It's good to see you. Rick, if you can unmute, well, you're already unmuted. Rick, if you can introduce.
Hello, everybody. I'm Rick Wallace, and I'm a librarian at the Quillen College of Medicine at ETSU.
Fabulous. Thank you, Rick. Aaron, if you can unmute and introduce, please.
Hey everyone, I'm Aaron Solon. I'm a behavioral health pharmacist at Nyack Hospital, New York. I'm joined with my APPE student. Say hello.
Oh, yay. Wonderful. It's good to see you again, Aaron, and thank you for bringing friends.
Yes, of course.
Thank you. Praveen, if you can unmute and introduce, please.
How's it going? I'm Praveen Panadapole. I'm a third-year psychiatry resident here at ATSU.
Wonderful. It's good to have you again, Praveen. Praveen has been attending with us since, I don't know, you were a first year, Praveen, so thank you.
Yeah. I don't always get a chance to attend, but I love it when I do get a chance. So I'm on lunch right now, but I'll be listening in. Thank you.
Perfect. Thank you so much. Chris Copeland, if you can unmute and introduce, please.
Hi, this is Chris. I'm a addictionologist at Revita Recovery in the Newport office, and having video camera problems as usual.
All right, sorry to hear you're having issues, Chris, but I'm glad you've joined us. Thank you for being here. Becca, if you can unmute and introduce, please.
Hello, I'm a nurse practitioner resident, and I'm working in the Mountain City Extended Hours Health Clinic.
Beautiful. Yay. I love having Mountain City on this call. Thank you for being here. I'm going to do my best and correct me when I don't do it well. Conweedy, if you can unmute and introduce for me, please.
That was perfect. My name is Conweedy Carmu. I'm a nurse practitioner in the ETSU Nurse Practitioner Residency Program, and I'm currently working at the Johnson City Community Health Center.
Wonderful. It's good to have you with us. I love having our nurse practitioner residents with us. Thank you for joining. Dottie, if you can unmute and introduce, please.
Hi, everybody. I'm Dottie Green. I'm an associate professor in the Department of Social Work and the graduate coordinator for our certificate in clinical addiction counseling studies.
Wonderful. Thank you so much for joining us, Dottie. It's a true honor to have you here. Thank you. Carmen, if you can unmute and introduce, please.
I am Carmen Jones. I'm a psych nurse practitioner resident with ETSU also, and I'm working at the Johnson City Community Health Center.
Fabulous. Again, another nurse practitioner resident. Hooray. Thank you. Ernest, if you can unmute and introduce, please.
Yeah, my name is Ernie Maupin. I'm a psych nurse practitioner, and I'm the project director for the nurse practitioner residency program.
Wonderful. It's good to have you with us, Ernie. Glad you could be here and see all of your students joining in. Probably makes you feel good. Suzanne, if you can unmute and introduce, please.
Yes, I'm Dr. Suzanne Fletcher. I'm driving, so I don't want you to see me, or I see you have a crash. So I am a internist by training, but I am currently working in retirement for my son, who is a psychiatry addiction double boarded in Goodlettsville, Tennessee.
Awesome. It's so good to have you with us, Suzanne, and please drive safe. And no, we don't want to see you get in a crash, so don't do that.
Thank you.
You're welcome. Christy, if you can unmute and introduce, please.
Hi, I'm also a nurse practitioner resident up in Mountain City.
Wonderful. Again, nurse practitioner, Mountain City. I'm loving it. You guys are awesome. Thank you, everyone, for joining us. Does anybody have any announcements or things that they would like to share before we launch into our didactic portion? If not, then I'm going to fiddle around with my share screen and see how badly I can do this before I get it right. So bear with me. Yeah, okay, good. Okay, are you guys just seeing a big interpreting your toxicology results screen? And I can only see myself, so if somebody can.
Yes, we do.
Okay, good. Yay, thank you. Good. All right, here we go then. Oh. This is my disclosure. I have nothing exciting to disclose related to this educational opportunity. So understanding what we're testing for with our toxicology screening and diagnostic testing, understanding the shortcomings and benefits of the different types of toxicology that we do in our clinic, and then understanding the interpretation and how we actually use that information when we do get it. That is what we're going to go over today in hopefully a brief amount of time. I don't know why that box is there. So what can we test? We can test a lot of different things. And if you have been working with anyone who's involved in the Department of Children's Services or with court or anything like that, you may hear of them testing things from nail beds, hair follicle, sweat, because they'll have these patches that they can put on that actually collects, you know, what comes out of their body as they run around all day, and test that as well. What we test here in our clinic, and I think that's what you're going to see in most clinical settings instead of punitive settings, is urine and saliva. Sometimes blood, but usually urine and saliva is what we're checking. So what are we looking for? Why are we doing this? So they only tell us about recent use. However, you can get that longer term picture. So if you're trying to figure out, you know, okay, so you haven't used in the last 3 days because my test is negative. And so, you know, most substances that we would be looking at would be gone from your system in that amount of time. But did you use something last week? So something with hair or nail testing is going to capture and hold that information for a longer period of time, up to a few months. What I didn't put on that previous slide is if we're testing somebody's cord. So a lot of times with our pregnant women, that cord will be sent and they'll be testing it to see what has been in the pregnant woman's system and potentially exposing the fetus to. So that is something else you can test that gives you that longer window of information. What we don't detect with our toxicology screening is whether someone's impaired. Granted, if you have someone who like does a word finding has been difficult lately. I'm gesturing. You know what I'm talking about. Someone tell me the word. What is it?
The breathalyzer.
Breathalyzer. Thank you. That does help us determine if someone's impaired or not, because you know you're on the side of the road and you have to blow in the apparatus, and they can determine your blood alcohol level is at a level of impairment. But if I've collected a urine drug screen from someone and it's positive, that does not mean that they are currently in that moment intoxicated or impaired for whatever substance they tested positive for. Because if someone used methamphetamines 2 days ago, it's going to be positive. It does not mean that they are acutely under the influence of the methamphetamine at that moment in time. So it does not detect impairment. Someone could be pulled over on the side of the road and blow on the breathalyzer and indicate impairment, but it does not indicate that they have an alcohol use disorder. It was their one-time bad choice, but it's not a series of events that led to finally being pulled over. Or someone testing positive one time for methamphetamines does not necessarily mean I have someone with a stimulant use disorder either, nor does it indicate dependence. Again, it's a snapshot in time. So I can tell what you've had, decent time frame of maybe when it's been there, but it's a snapshot. It's not something that's telling me the whole picture. It is an entry. It's a paragraph in the story of their life. So point of care, you guys probably have had some of these in your hands, have seen them and looked at them. This is actually exactly the cup that we have in our clinic. It has this little strip at the bottom that gives you the temperature read. I do not put a lot of faith in my temperature read because it may have sat in the cold little metal box next to the lab at the bathroom that joins our lab, and it cooled down quite a bit by the time we get a chance to read it, just even over a few minutes. But the important part is you can see it a little bit on this one. There is an adulteration strip in the one where you can see the use screen written on it on the very far right. So an adulteration strip is really helpful to have there. So someone should have creatinine in their urine. And when that creatinine is 0, it makes you wonder a little bit, is this actually urine? Or does my person have some issues with their kidneys that I really need to be getting some blood work for to test and see what's going on? Because everybody has creatinine when they go pee. And then when you look at, I don't know why they decided this is how they were going to do it when they did urine drug screens. Unlike a pregnancy test or a flu swab or a strep swab, if you have 2 lines, it's positive. unless it's a drug screen. If you have 2 lines, it's negative. So you're positive for a substance if your test line is blank. It really took me a long time to wrap my head around what this is, because I would look at my patients' urine screens in the very beginning and I'd be like, good Lord, there isn't anything they didn't take. Well, that's because double lines is negative, single line is positive. So if it's not something you've gotten 100% used to yet, don't worry, it comes. For those of you who are like, yeah, I totally read it and I don't bat an eyelash. I know one line is positive. You can remember the days when you first looked at it and you were like, wait, what am I reading? Because it is different than any of the other point of care testing we do. That's a positive, negative type of screen. And then the guy that tells us more information, the gas chromatography, mass spectrometry. So this is when we send it in. This is typically what's happening. You can get liquid chromatography, mass spectrometry, but typically what we're getting when we send in our toxicology samples, they're running as a gas chromatography, mass spectrometry. So it is quantitative. It will report back not just the qualitative positive, negative, but it will also give you a value of, there's 1,951 nanograms per ml, for instance, or there's 30 nanograms per ml. So you get a quantity amount in that sample, how much is there. It is more expensive to run the quantitative GC mass spec, and you do have to wait. These get sent off and it's about a week before you get your information back. But on the upside, it positively identifies the presence of a particular substance. The signal that is created when you put it through the gas chromatography mass spec machine is unique to that substance. So you're not going to have morphine that shows up as anything other than morphine. That's what it's going to be. So you can really pull apart your hydrocodone, your codone, just all the things that are on here. One of the things though, when you do look at your results, just knowing the metabolic breakdown of the substances that are being tested, because you may see something that you're like, why is that there? That shouldn't be there. And then if you actually look back and review the metabolic breakdown, it's a metabolite and it makes sense that it should be there. So it takes a little bit more than just glancing at positive, negative, but recognizing the metabolic pathways as well for the breakdown products of the substances that we might find in our patients. So there are some point of care oral swabs, which is what you're seeing here. Some of them you can just literally, just like your urine cup, and then some of them, the one in the middle, the big picture, that's exactly what ours look like, but we send those off. Our orals all get sent off. We do not have point of care in our clinic. You may have worked in a clinic where they do have oral point of care. And point of care is great because you get information quickly, but sometimes you can get some false positives. Are you guys seeing the green box? Do you have a green box? Okay, there's an annoying green box on my page and I don't know why. Okay, as long as you guys aren't seeing it, that's all right.
Is it at the very top, Dr. Troxler?
No, it's a green box that goes around the content on the slide.
Okay, I bet it's just because it's sharing that slide, but we don't see that. So
okay, all right, good, because it's covering up some stuff. So I just
okay,
need you guys can see the full slide unobstructed. Okay. So when we are testing, I kind of alluded to this a moment ago. If someone used methamphetamine 2 days ago and they give me a urine sample, it's going to be positive on that point of care urine sample, most likely, because you can see methamphetamine is about 48 hours that it can be detected in the urine. Marijuana, completely dependent on how much and how long someone has been using. So someone who is smoking 3 to 4 joints a day and has done that every day for the past 6 months and they stop, you're still going to see them be positive for quite a few weeks after they've stopped use. Sometimes it's helpful with that quantitative I was just showing you guys, where you can sort of see the numbers dropping down as they get more and more time away from the substance. Heroin, 48 hours. Lorazepam, short-acting benzodiazepine, just a few days. Long-acting benzodiazepine like diazepam, up to a month. So know the substances and know how long you're going to find them. Because if you test positive and you've not used, and then your provider is like, but it should be negative because you haven't used, but it's a long-acting substance, it could still be positive even though you haven't used. So keeping that in mind. Buprenorphine, 3 to 7 days. I'll be honest with you, and maybe you guys, some of you all on the session today have more information about this that you can educate me with. When I've looked to see like how long can I pick up buprenorphine on a urine cup after someone has stopped using or someone's run out of their script and they haven't had any, I will still see it positive up to a week out from last use. When I was reading, I didn't find anything that gave me a very definite, unlike methamphetamine, 48 hours. I've also read some that methamphetamine up to 72, but it was pretty consistent, all the things that I read. But buprenorphine was something that I didn't come across that much data to like nail it. This is what you can expect. So when we get to the discussion part, if somebody has something to say about that, I'd love to hear it. So different substances, measuring different substances. So if I get urine, I can expect a few days worth. That's what I'm going to be seeing a picture of. If I get blood, you know, a little bit less time than urine. If I'm getting sweat, or I'm getting hair, or if I'm getting oral fluid. So what you're testing will hold the information for a different amount of time. So don't expect to get the same type of information from a blood draw as you would from a urine to detect how long ago someone maybe used that they would still test positive for it. Many substances are metabolized by the liver and excreted in the urine over time, which is why using urine 1, it just keeps on getting remade. You don't have to take a needle and poke anybody to get it. People tend to have it with them wherever they go. Hopefully theirs and not somebody else's. And because it is continually being processed and excreted, put into the bladder to be released into a toilet bowl or behind a bush, we have a ready-made source of it, and it is giving us information over a decent period of time. So even if we're only seeing someone weekly, if they have used within that last week, the window of opportunity is open a little wider with our urine. And that's why doing urine point of care in clinic is really beneficial, because we have something right then, right there to discuss. Instead of waiting for results to come back and it's a week later from where we've done a send-in. And we're trying to remember, like, when I saw you last week and you told me you hadn't used anything, and then I got my confirmation and it showed that you had, you know, it's an easier, quicker, right now, let's talk about this when you have the positive in hand during the same visit. So that's a really good benefit of having the point of care testing to discuss with your patients at that moment. However, the potential of false positives and false negatives is very much there with any point of care testing you do, whether it's an oral swab that's point of care or urine that's point of care. So these are some things that will give you a false positive for amphetamine. That's a lot of different things. So just keep that in mind. If someone tells you absolutely no, but they're positive, you may want to review medications either over the counter or other meds that you may not know about that they're prescribed. Phentermine's a big one here lately for us, that's going to show them as positive for amphetamines. So keep that in mind, get the history from your patients. And then when history and results still do not match up, that's where the send off for confirmation comes in handy. So just a metabolic pathway of benzodiazepines. So typically your clonidine, clonazepam will not be positive on most point of care urine drug screens, because most point of care urine drug screens are looking for oxazepam. I'm not going to go into a discussion that I'm going to screw up of exactly how the point of care works, but it's an immunoassay. If that helps anybody understand how it's grabbing and lighting up or not lighting up on that test strip. So if we're looking for oxazepam as a metabolite in the urine, we're going to get that if someone has been taking Valium or diazepam. Oxazepam turns into the glucuronide conjugates. So our alprazolam and lorazepam will pass through that. So we'll pick them up that way as well on most of our urine cups. But as you'll notice, clonazepam is not on this list. It does not pass through that pathway. So we're not going to find it on our cup. And so sometimes with that one, the only way to get it is with sending it off for confirmation. So just keeping that in mind. I just said all of these words, but here's a whole slide that you'll have access to that says it again. So opioids is a very broad term, just a little semantics lesson. Opiates are specific to the naturally occurring opioids. So morphine, codeine, and heroin, those are opiates. Opioids is anything, whether it's synthetic, semi-synthetic, or naturally occurring. So when you have a urine drug screen, some of them you'll notice there are two different strips for your opioids. There's going to be one that's looking for your naturally occurring and one that's looking for like those semi-synthetic synthetics. Oxycodone in particular, you need to have a different test strip on your urine cup than the one that's looking for morphine, codeine, or heroin, because they typically will not test positive one or the other, depending on levels and contaminants and that type of thing, possibly. But typically oxycodone will only show positive if you've got one of those synthetic test strips, synthetic opioid test strips on your urine cup. It will not test positive. So if it says, I think this is what the next slide is. Nope. Well, this is what I'm saying now. Then it will show like morphine or OPI, MOR or OPI is usually what's on the test strip, what's like written to the side what you're testing. These are the substances you're testing for. It will say MOR for morphine or OPI for opiates. And that's where you're going to find your heroin, morphine, or codeine. And then it's just going to be a test strip that says OXY for that synthetic, semi-synthetic, and typically picking up your oxycodone. If you're looking for methadone, buprenorphine, or fentanyl, you need a methadone test strip, a buprenorphine test strip, and a fentanyl test strip, because nothing else will test positive for methadone but methadone, buprenorphine for buprenorphine, fentanyl for fentanyl. They're not going to show up as an OPI or a MOR on your urine cup or an oxy, unless they're contaminated. And then maybe they will, but we're gonna miss, especially fentanyl, if we're not looking for it specifically. And this is just kind of what it looks like. If you want to look at this slide and figure out which cup you'd like to order, so you can get, the one that's going to give you every possible thing, like the one over here. I don't really like the name of this slide. I actually borrowed this slide from a friend. The cheating, or someone's not feeling comfortable enough talking to you about what they've been experiencing, what they've been doing. Maybe they had a return to use that they're not really wanting to talk about. They just want it to be like, I did something I don't want to talk about. I'm going to give you someone else's urine. I'm going to put water in my urine. I'm going to do something else. So I don't have to talk about this because I don't want to disappoint someone. I'd like to believe that I'm still doing well. And if we have to have a conversation about my return to use, I'm not going to feel like I was doing as well. So for me, it's a conversation starter. If I get something that's wonky when I do my point of care testing, or when something comes back wonky from my confirmation, it's an opportunity to, one, reassure the patient why we're here and what we're trying to get done, and why it's important to talk about what we've been experiencing, the good, the bad, the ugly, and everything in between. I don't observe urine collections, and it's a policy that we adhere to in the clinic where I work. We do not observe urine collections. Many of our patients have been subjected to sexual abuse, and watching someone pee is weird, whether you've been subjected to sexual abuse or not. It's weird. I feel as though it's putting your patient in a very diminished status to be in the bathroom with them. So we do not do observed urine collections. We do observe oral swabs. So that's how we get our observed collections. You can also do a blood draw as an observed collection. So I know a number of clinics do use observed urines as a way to collect their specimens and observe and know what they're getting is what they're getting from their patient. There are definitely ways, even with observed urines, to get around that. There are ways to get around the observed saliva as well. But truth of it is, when we are using our toxicology screens, it is an opportunity to talk to our patient about what they've been experiencing. And even if, they just swish and spit, half a bottle of Listerine to try and trump their oral swab, or, they brought somebody else's urine to put in that cup, it may not be on that visit that I know what's going on, but you can tell by other things your patients are doing, and hanging decisions on what's in a cup or what's on a swab or what's on your blood draw. You're missing a lot of the picture of what's happening with your patient. They continually keep visits. They follow through on their behavioral health requirements. They've gotten custody back of a child. They've gotten a job. Those are really, really good ways to measure how is your patient doing. And And the toxicology we collect is just almost like you got bumpers on when you go bowling, like trying to keep the ball from going into the gutter. You know, it's gonna go down, it's gonna hit a pin. We keep working, we keep trying, we keep coming back, we fall down, we get up, and eventually we're gonna hit a strike. All those pins are gonna go down. So using whatever toxicology mean you're using to kind of help keep your patient, you know, getting that bowling ball down the alley and hitting a pin or two, maybe 9, maybe 7, maybe all 10. That's what we're trying to do. And the toxicology screening and testing that we're doing is just meant as a way to kind of help keep us all on track, and some degree of accountability and opportunities to have conversations when things aren't going as we had hoped. Sometimes after we get it and we come back in, so, you know, are you going to tell me about, you know, it was positive for methamphetamine today. Do you want to talk about that? And then the conversation starts. If we hadn't had that result and we just gone through the whole visit and not brought it up or mentioned it, that the patient wasn't going to bring it up themselves. So it's a good way to have a conversation with the patient right then and there about what they've been experiencing. Difficult to interpret, potential for false positive, potential for false negatives with the point of care. Send it off for the confirmatory if you don't think what you've gotten is a real picture of what's been happening. It's for screening. It's a way to check in with your patient. And if I have a urine that's just completely, I don't think this is yours, I don't think this is human, I don't know what you put in the cup, would you like to talk to me about, like, why did that happen? I don't need to go back and get another cup. I don't need to put a swab in their mouth, and I don't need to do a blood test. When they start telling me about, yeah, I brought somebody else's urine, that's not mine. I really didn't want you to see that I started smoking pot again, or that I had return to use of methamphetamine or whatever. So if they confirm by their history, that's my confirmation. I don't need to have an expensive test to confirm what's going on. So you can confirm by history. So if you come back after a point of care and they tell you, yeah, no, not mine, or yeah, yep, that should be there because I did that 2 days ago, you don't have to send it off. So confirmation by history or by gas chromatography, mass spectrometry. Those are my resources. And that is done. I'm stopping the sharing. All right, there are a bunch of chats down here, so I'm going to open those up. Oh, because our wonderful Rick Wallace has been at it again and sending us fabulous links to articles. Rick does this each and every time. I think some of you guys are familiar with him doing this. Those of you who haven't been on in a while or you're new to us, Rick will put into the chat that he finds really pertinent articles to the things that we're talking about as we're talking about them. So thank you, Rick, for putting those up. We've also had someone join us. I'm going to get to introduce Joey. If you can unmute and introduce, please.
Hi, I'm Dr. Joey Tucciaroni. Just about a month into my fellowship here at Family Medicine, graduate of ETSU. Just very, very happy to be with you all today, and looking forward to seeing where things go from here.
Beautiful. Thank you for joining us, Joey. It's nice having you.
Thank you so much. Appreciate it.
Welcome. Any questions or comments from the toxicology? I've bored you all with science. I'm sorry. Right, we do have a case, so let's get some conversation going with that. I'm going to let Veronica present her case to you guys.
Okay, thank you, Dr. Troxler.
You're welcome.
So I'm just going to go ahead and start off with the question. Actually, it's just more of a statement. So as I'm going through presenting this patient, that you guys just can be thinking, you will see it's very complex. And so any and all recommendations on a medical level, on a social work level, on any level, is welcome and appreciated, especially this patient's next steps and resources for her. So she is a 29-year-old female. I don't know much about her past medical history. So I've worked with her as a certified peer recovery specialist for a few years now. Not sure about her past diagnosis as far as anything with psychology or psychiatry, but she has been to inpatient that is known at least 5 times in the past 6 years. Most recently, she was at Cornerstone and she was living at a halfway house in Knoxville for a few months, relapsed while she was in the halfway house, went back to Cornerstone. I think they have a separate program there called Stepping Stones. This was all within the past year, and completed that program and went back to the halfway house because it was contingent based on that she completed that program. But while she was inpatient this second time, her mother, who was one of her sole support systems, passed away of cirrhosis of the liver. Her father is estranged from her. She had a stepfather that had also passed away about 4 years ago, and it's kind of what has fueled, this loss has fueled her return to uses. Let's see. So she is recently, as of today, has been recently admitted into a psychiatric facility due to a suicide attempt, but doctors are suspecting that it was an accidental overdose. She has had 3 overdoses this month so far and has been Narcaned out of them each time. She is currently using methamphetamine and heroin. She is currently homeless now and pregnant with her second child. And she has no custody of her first child. The paternal grandmother has custody of the first child. Her social history, so again, I had alluded to her parents were divorced at a young age. She has brothers and sisters that are all older than her. She's the youngest and they are a huge support system, but she has, for lack of better terms, burnt her bridges with them due to some past behaviors. Let's see, she, like I said, her biological father is estranged. She actually, so whenever I first met her, she was in recovery. So she has been in AA and NA. She is very well accustomed to the program. She has had a sponsor, worked actively for over a year when she first got into recovery. This was, I guess, about 4 or 5 years ago, and was doing well and decided that she was going to join the Marines. So she joined the Marines, and this is kind of where it really took off. Her alcohol was introduced to her while she was in the Marines. This is when she lost her stepfather. I know I'm bouncing a little bit. Hope you can keep up with me. But while she was in the Marines, she started using alcohol pretty heavily, which just turned into her return to use with painkillers. And not long after that, she, within a year of her joining the Marines, she was dishonorably discharged. And so ever since then, it's been kind of a battle, this back and forth of getting into going to inpatient. She's very familiar with inpatient, very familiar with the programs, the 12-step programs, and but most recently it's gotten to be a little bit more heavy on her. So not only did she lose her child, but she lost her child in the middle of when she was staying in Kingsport, and the and SWAT team ran in on her apartment that she was staying on with her child. And so she legally has, she's facing 4 felonies right now. I'm not sure at the place where the felonies are right now. I know that it was put on hold because she went to, this was her, why she went to Cornerstone to, in Knoxville. And to complete that program, I think they were going to at least amend them down to a misdemeanor if she completed that. Where all that is known. So if she does have a support system and a friend that she only contacts when she's in treatment, this friend does not hear from her when she is not in treatment, when she's not doing well. And her family is there to support her when she decides to go to get help, but they have put up their boundaries that they've needed to because of her, just her past patterns. So that's her. If you could keep up with me, any clarifying questions, I know that I can constantly bounce around, but I mean, to sum it up, right now she's in a psychiatric hospital with that she's just Narcan this morning, and she is currently using IV heroin and methamphetamine, pregnant and homeless.
All right, any clarifying questions, guys?
Veronica, is there something specific you'd like feedback on, or is it just kind of like a general global, like, oh my gosh, what do I do with this?
I'm sorry, repeat that.
If there's like a specific clinical question you'd like feedback on?
No, it was literally, oh my gosh, what do I do with this? Yeah, I mean, just because again, she is no stranger to the 12-step program to inpatient. I mean, we've gone all the way from the inpatient from Galax, Virginia to Knoxville to Kentucky. We've been quite a few places that she does well in for about 60 to 90 days, goes to the sober living facility. So yeah, so pretty what help anything, I mean, medically, anything, any suggestions for her at where she is at this point?
You said she's homeless?
She is.
Is she sheltered homeless, or is she?
I'm not sure where she was before that. Again, this was all brought up to me this morning. She has been a patient of mine for quite a while, but loses touch with all of her good support systems while she's out there. So I'm not sure how long she's actually been back in Kingsport since leaving the halfway home in Knoxville. But currently she was at the emergency room for the past 2 days, and now she is in a psychiatric facility right now. So, but as far as she doesn't have anywhere to go when she leaves.
Okay.
Veronica, what's the longest residential program that she's participated in?
I believe it's been this past one at Cornerstone.
90 days.
Yeah, and 90 days, and then she went into the sober living facility directly after that. So it has been at least since March she's been back and forth, but again, since March when she was there, she went to it 90 days, went to the halfway house, had a return to use at the halfway house, and so they wouldn't kick her out. She went back to Stepping Stones, and then I'm not sure what's happened since then, to be honest.
I'm wondering about, and I apologize, I'm not as familiar with Tennessee's resources, but I came from the Asheville area, and there are 2 long-term women's programs there that I was wondering if that might be something to consider. And the first is First Step Farm for women, and that it might only be for North Carolina residents, I'm not sure. And the second is First at Blue Ridge. And they can stay for, I think First at Blue Ridge might be up to 2 years. And First Step Farm, I believe, is up to a year.
And are these for women, solely just women? Okay,
yeah.
And I don't know if you have this information or not, would it be an issue that she was pregnant?
Well, it would be, I guess it would depend on when her due date is. Yeah.
Okay. Thank you for those. I've heard,
yeah.
I'm not very familiar with a lot of resources in Asheville, so that I believe that is a state we haven't treaded yet, so.
Well, somebody just put something in the chat about.
Oh, Dottie, you just muted yourself, Dottie. I think it's okay.
Oh, the Strong Futures. Okay, I don't know anything about that.
Okay.
I would love to hear
I'm
about
familiar
that.
with Strong Futures. I actually didn't even think of it, so thank you, Carmen. That is something I didn't think about.
Do you know how far along she is in her pregnancy?
I do not. I just found out she was pregnant. This is all very new where she's at as of this morning.
Okay.
The other thing that, comes to mind for me with this particular client is my guess is she's probably got some pretty significant trauma in her history, and just wondering if that doesn't need to be addressed too. Just a thought.
No, I agree. I unfortunately don't have all the information of what kind of, therapeutic style. I know Cornerstone, I'm a little bit familiar. I'm sure she went to counseling while she was there, but the consistency of it, or if she did any kind of trauma counseling, because I think that's the key for her to be able to work through her, because I do know there was some childhood abuse there. And I'm not sure, again, if how deep she's gone into that work.
One more question and then I'll stop.
Yeah, no, you're good. This is great.
Has her sponsor been consistent and one sponsor with her throughout the last few years?
Yes.
So
Yes,
that's
she
a
has.
good relationship there.
Yeah, it's a very good
Oh,
relationship.
that's
This is-
excellent.
Yeah, this is the person that has taken her to all the inpatients that she unfortunately does not contact when she's out, running, but she is always there, willing to pick up the phone when the phone rings. So,
yeah, good.
Yeah.
Okay.
What was up with the SWAT team and the felonies? What was that about?
I'm sorry, with the felonies?
Yeah. No, SWAT team.
SWAT. So there, she had an apartment, from what I understand is she had an apartment in Kingsport with somebody that she was dating. Her child was living with her, and I can't remember all of the charges, but I know maintaining a dwelling was one. I believe this was pre-Cornerstone. So this was probably in 2009, into 2019. It was like right when COVID was starting. And I'm sure she was selling methamphetamine and things like that. But this was when her mother was still alive. This was after another stint. She had a stint in early 2019 in the inpatient in Galax, Virginia. She comes home, and this is kind of her pattern. She does well. She gets in touch with her sponsor, starts going to meetings, but no offense, men, but she gets involved with the mail, and it kind of goes from there. And so she had gotten an apartment with this individual, and next thing you know, SWAT's coming in. They're busting them for methamphetamine and maintaining a dwelling. And this is when her first child was taken out of her custody, and she went to Cornerstone contingent. The felonies I don't think have been completely closed or answered for, because it's been contingent. So she might even be on the run right now. I'm not sure of that. So I hope that clarified your question.
Has she had any involvement with Families Free?
I don't believe so. I don't. That's
Maybe another thing to think about, because they have tons of resources and there's no limit, and they will work with, pregnant women. So, and recovery court, is she involved with recovery court with the felonies?
Which surprised me, because I'm very familiar with recovery court, which surprised me that they did not offer that to her.
I know, that's curious.
Yeah. So, but again, I'm only getting the story that I get from, not sure about all the super details, but the details that I got this morning were from one of her providers at the psychiatric hospital. So I know that much.
Families Free might be able to get her involved with the recovery court too, if she's got some pending charges, or
at least advocate for her. Especially if she's got a warrant out. That's a good idea. Thank you.
And that just might put a little extra kind of monitoring in place for her.
Does she have access to any sort of case management at the hospital?
Yes, I'm sure they do have case management there.
Okay. Because they can be the direct link to Families Free, to the River, who, they specialize in resources specifically for women. So they might be able to get her networked and connected to places like Arch, or I don't know, Family Promise, or Good Samaritan, or it's hard to know who has what funds available right now. So somebody could get on the horn and start doing the legwork in terms, just determining, because we have all these different agencies, but they all have different amounts of money for different things at any one time. So it's really hard to pinpoint, exactly where she's going to be able to go. So if somebody's willing to do that legwork ahead of time and save her the hassle of ping-ponging all over town, trying to find some help with getting established housing wise and getting connected to recovery court, et cetera, that would be so helpful.
Yeah, thank you. I totally agree. My hopes is this, the case management there will help connect her to those different resources. My fear is though, in my experience every day, I encounter a lot of barriers because there's a lot of red tape on accessing these resources. A lot of it, especially emergency shelter, especially any kind of housing. If you have a felony, you might as well count it out. Or if you have any drugs in your system currently, emergency shelter is hard. So, but hopefully, but like I said, she's at the psychiatric hospital. So she will have time to be able to get herself cleaned up and get some access. And honestly, at this point, I'm not even sure she's willing to want help. If it was offered to her, I'm just trying to figure out things to offer to her before she screams,
Yeah.
Do you know if she has, go ahead, George.
I was just saying, fair enough. Yeah.
Veronica, do you know if she has been on any type of MAT in the past?
She has, and I think that was one of her longest stints in recovery is whenever she was on, I believe she was on MAT when she became pregnant with her son to stay, because she did not use while she was pregnant with him and for a good while after. So, but I'm not sure. I think that ended quickly.
Okay.
Well, I think that the first thing is the basic need of any human being, a place to live and somehow to support herself. So I think that's the first thing that comes on board. But in the long run, lots of this other than honorable discharge, that's how they put it. They don't say dishonorable discharge. They call it other than honorable. Can be reversed if they go after it, and then it would be a whole entire, VA is going to be available for someone who is changing the other than honorable discharge to the medical discharge or honorable discharge. That can happen. And that's a very, lengthy, process. It's not something that it would acutely help at this moment. Another thing is people that they are other than honorable discharge is still qualified for at least 90 days of the mental health treatment from the VA. And that is started like 2 years ago. So it can be a residential or inpatient service or outpatient mental health clinic. It can be available to them. And that 90 days can be expanded to the 180 days if it's necessary by the provider that is providing that service.
And she would call the VA for that?
From the VA, yes. And it's only for the mental health, not other medical problem, but substance use is one of those mental health problems that can be treated. But that's required for the patient to really go there and ask for.
Okay, great. I didn't know that. Thank you.
And during that period of time that they are in a recovery and the residential social worker can help them to at least apply to change the picture of the other than honorable. And most of the time I hear that the patient either are suffering from some PTSD or substance use problem, and they get engaged in some behavior that causes them to be discharged other than honorable. And because we know those are the disease that is related to that behavior, then they can turn it around. But the question is she eligible for the VA at all? Like if you've been in a training only one day and that happened, usually you are not eligible for VA.
I do know that she graduated boot camp.
Okay.
She graduated, she was already on a base. So she was there for over a year.
Yeah, if she was in the military service for a month at the time that you're saying that she would be eligible.
Okay, great.
Carmen has been burning up our chat box with some really good resource ideas. Thank you, Carmen, for putting those there. A link to Families Free for anybody who wants to, if you haven't heard of Families Free before, you can hit that link and learn more about them. But also just some of the services that are available through Frontier Health, their mother-child connection. That's an IOP, an intensive outpatient program they have there as well. So I think taking an individual who's in a very acute setting and letting that settle down a little bit and determine what what needs she has and where she is in her desire to engage in addressing those needs. So this is one, Veronica, I think that will unfold over time. And we need to have an update on what goes on. Meredith, you have something to add?
Yeah, I don't know whose Narcan was used, but if it was her friends, family, people she's living with that had used up all of their Narcan on her recently, I would definitely check and make sure that those could be replaced. Because I think, like Cameron said, dealing with the most immediate needs is, I think, with her recent history, the most immediate need is keeping her alive.
Yes.
So.
Excellent point, Meredith. Anybody else with some closing thoughts on this case?
Yeah, I was just wanted to take a moment to acknowledge the challenge of this case and cases like this. I think it's really important to recognize that there are only so many things that you can do as a provider, and I think it's all too common. Oftentimes, we take a lot of ownership when we're trying to help somebody as high need and high risk as this person is. So I just hope you're giving yourself a lot of compassion and a lot of care, and taking care of, just like your own self, no matter which direction this goes, whatever that's worth to you.
Thank you, Joy. That's actually very important. I think we do forget and lose sight of the relationship. It's not just our patients, it's us and our patients. So thank you for mentioning that. We do expect follow-up.
Oh, listen here. You want me to, I'll do the weekly submissions every 2 weeks.
I'll just follow this patient for the next 6 months. But on that point, we will get an update on this maybe a few months down the road. Cases from you guys, as you'll notice, the didactics, I'm certain, riveting and totally exciting watching me flip through those and talk at you through a mask. What generated the most conversation, all the conversation today, was the case that Veronica presented to us. Cases are vitally important to this this coming together that we share every other week. So you will be getting invitations in your inbox shortly, inviting you to present a case. So come up, anything, something, we want to hear about it. Veronica just presented us a case today that was, whatever you have, I want it. Ideas, resources, thoughts, directions. I think you probably got more than you bargained for, because we had some really kind and encouraging words from Joey as well. Just remembering ourselves as part of this very important dance with our patients. So please, guys, submit your cases. We want to hear what you're seeing, what you're experiencing. We want to be a support to you, okay? So when you get the invitation to the dance of a case presentation, please do not turn us down. Come forward with something, okay? We're back together again in 2 weeks. I look forward to seeing each and every one of you. On the in-between, if you need to reach out to us, please do. Go to our I Am Echo ETSU website. You can find all of our contact information there. I think it's on the slides as they rotate around as well. But you know what? Most of us are ETSU folks. It's not that too hard to find us. You can just search us on ETSU website. So, all right. Before we go though, Jack, unmute and introduce really fast because you joined while we were in the middle of the conversation with food in your mouth.
Jack Larson, I'm one of the third-year residents at ETSU Family Medicine.
Great, thank you, Jack, for joining us today. And then over in the corner, she thought she could get out of it.
Hey, I'm Tanya. I'm the medical assistant for the fellowship.
Thank you, Tanya. All right, everyone, if I missed you, I'm sorry. It will not happen again. Good night. Good night.
Good night.
It's been a long day already, everyone. We'll see you in 2 weeks.
Time to go to bed. Heard it from my boss.
You guys go have breakfast and lunch and dinner, whatever you want.
Oh my God. I don't know. I think it's good we only do this every 2 weeks. Oh.
Great to session, I think that the case was very important and
Yeah.
and it's in the beginning and it's still something that is developing. And yeah, I wouldn't be surprised if you bring this one back and give us an update even next session. Because it's 2 weeks period and you can say, hey, then yeah, there was a placement for it. Yeah.
Yeah, I just hope I'll have an update, well, at least have an update from my contact from where she's at right now, but if she goes back out to the street, she'll ghost me, so, but we'll see.
We'll see. See what
Fingers
happens.
crossed.
So, Melissa and Meredith and Cameron, from a hub standpoint, I told Rebecca today, we are just going to start assigning people dates for cases. So, because this was kind of a like, oh, case, crap, nobody submitted anything? What are we gonna do? And in the Our Joy Echo that we've been doing, people were assigned. I think in the beginning, they kind of set up the expectation, like you are going to participate in this, it is not voluntary, and you're gonna get an assignment. So it's very different than ours, which is 100% voluntary, except for the nurse practitioner students. So actually, Rebecca, that Ernest Maupin, he is their director or something. I can't remember all the pieces parts and how that works together, but he's a clinical lead for them over there. So you may want to reach out to him and let him know that you're actually going to be kind of sitting these out like assigned times to do. Because getting him on board with this is, because they require them, actually, they are not voluntarily joining us. The nurse practitioner residency program requires them to participate.
And I have the updated list of emails too, Rebecca, to send you that Ernie sent me this morning.
Perfect. Good. So we can kind of connect with him a little bit on that, and you may want to just do that dive first. As far as connecting with him, and like we are wanting to make the case presentations actually an assigned portion. So if you can buy in on that idea and help us out, it would be appreciated. But then I think also for our other hub, participants, that we're just gonna assign them, give them a couple of choices of dates, but like you're expected to give a case presentation at this time.
Well, I'm talking about you're talking about everybody else or just the students and the residents?
Chris Copeland gets one, David Rohn gets one.
Well, that's.
Praveen gets one.
I know, but that is I think that participation in ECHO right now is voluntary. Participation, and so nobody's mandated to.
Except for the nurse practitioner students.
Just those people. So for that reason, if you are, forcing someone to come up with a case, they may not have a case and they don't show up.
True. So that is a potential backfire of the plan.
I'm with you, Cameron.
So when I told Rebecca about it, I'm like, we'll either get something back from them. So we'll put it out there like, hey, we would love to have you submit a case. Here are a couple of dates. Which one works for you? So it's not so much of a you required now you must do this, but much more of a much
strongly suggested.
A personalized invitation. I think that's the way to go. Yeah, because I'm with Cameron. I think that those people might just be like, oh, I can't come anymore.
Not doing that because you're asking for something from me. But I think if we put out like, here's some dates, we really want to hear from you for your case. Do any of these dates work for you to present? If nothing else, if we get 20% participation in submitting cases, that's going to be a hell of a lot more cases than what we've got to work with right now.
Yeah, no, the psych term is social loafing. You just you let everybody else do it. So how to circumvent the social loafing is you specifically say, you in the red shirt do CPR. So you in the red shirt do a case. Yeah.
Yes.
And I think another area of that is going to be like, we have Ernie for the nursing, but also since we have a lot of Johnson City students, med students and residents that's been joining us, if we could get someone in charge of them to kind of, like their rankings to encourage down, I think that would be something.
Yeah, we can simply assign you need to come up with the case and present it that day to the student and resident and fellows.
Yeah, anybody like that in that kind of
no question on that one, because that would be some kind of performance measure for them. They need to do a good job on that one. But what I'm thinking is, if we are reaching out to the attendings that they are fully voluntary coming here to being involved in this situation, I would approach it to the way that if you have a case that you feel that it would be educational for other members of the, group, we would love for you to one of these days, you choose and you present that case. They may have a, no question about the case. There was an approach that they have done in some difficult cases that they resolved was, very therapeutic at the end of the case, and kind of case presentation. But they can, put it in a way that creates some discussion. But we need to ask them to do that. That way, it may motivate someone like Cameron Hile to come up with something and come up there and say it. Of course, we are a little bit, protected with being a hub member from that, mandate, but generally, I mean, that would be my approach for those like Copland or, those attending that they are providing some feedback on this situation. But for students, unfortunately, I think that they are mandated to do things like this. And we've been there, we've been pushed by our attending to do the same thing. So what goes around comes around.
David can do one.
Yeah.
Yeah.
That Melissa, what happened? Because last time we had like those billion of the family medicine residents, where they didn't come back.
That was their didactic for last time. Like they planned it into their didactic schedule to come for it for Johnson City. I'm working with Kingsport and Bristol to see if we can work into their didactic session so that they can attend during it. But usually on Wednesdays, their didactics start at 12:30. So I don't think that they will be attending unless it's on their calendar.
Okay, so that was just, I thought they like had like added us in, not that this was like a one-off.
It was a one-off, but ideally, it's like, look how easy this was. You got an hour of content and you didn't have to do squat. Besides, make certain you didn't schedule something else during that time.
Yeah.
So it would behoove them to see and maybe Rebecca just because seriously, you just go on the website and look, but we got to make it easier than that. Just send them our schedule. Like, this is what's happening. It's already set. Tune in. You got an hour claimed. Your job is done. Because really ACGME, common program requirements for all residency programs, is they need to have exposure to addiction medicine. We have the friggin' curriculum for them already. All they have to do is tap in, and then ACGME site visitor is like, I love you. It's already done. So many people are doing this. This is so easy. Here it is happening under your noses. Tell your people.
I got an email from, it was like something like Health Equity Club or something like that. It's a medical student club. And they had asked me, they're like, can you teach MI? We see you have an echo presentation on MI. And I was like, yeah. And I was like, you should come to the echo. And they're like, well, can you like give us like we have an hour on this day. Can you like do more for us? And I was like, yeah, fine, I can. But like, you should come to the echo. So I'm hoping they'll come to that one. Yeah. But I don't know.
I'm hoping that the more that you're working with them, Rebecca, they're going to kind of see this, how helpful it is this year, and then start building more into that. Yeah. And another thing too, we had discussed before, is sending out to the College of Medicine. So for the October 20th, I'm gonna send that out again and just add a few more dates to that one. And just try to do that like quarterly, because I don't want to like bombard them with stuff, but I want them to all be familiar. Like, I mean, we got like Dr. Peer and a few of them before that's how we kind of recruited them.
Yep.
Well, and then Melissa had brought up, which I wanted to float to you, Joyce, was there's the psychology undergrads are required to attend like a certain number of presentations a semester. Like I don't even know how many it is. And they come to things, but I don't know if we want them.
Yeah.
Like we could get like 80.
Oh, wow. Is that a hesitation because of the volume, or is there another reason? Like, don't know if we would.
They like online things with ETSU people. I think seems to be their preference. And particularly the one that will be like the last day before the end of the semester. Well, yeah, you could get like 80. But I don't know.
And I mean, I feel like the exposure would be good. Like, I don't know if they could really help resolve like in a discussion, but I was kind of thinking maybe like the exposure route, because if you have people going into that, maybe it would help them guide that direction for grad school.
And Melissa, we'd be able to like send Dr. Ellis like a list of participants. So that's the other thing. So if they go to online talks that aren't ETSU, they have to write a summary, like a little paragraph summary of what happened. And if they go to an ETSU CME type one where Melissa can send the attendance list, they don't have to write a summary.
No wonder they like ETSU online. Yeah. Low as possible.
But so if we're interested, we can pull the trigger anytime. But if we want them, I can send an email and we can get, 2 to 100.
Okay, well, but I mean, I think the more the merrier. Having to look at 100 different little tiles is going to be impossible.
And it's just be named because no one will turn their camera on.
Oh, so I can actually make those go away and just see the people with the camera on. Awesome. And then I'll have like 10 tiles. And it's all hub team members. What do you think? I see no reason not to, other than just the number. I mean, because they're gonna have their camera off and they're just gonna let it run and say, I attended. And the idea that they're gonna be disruptive and rowdy and talking out of turn, probably not gonna happen.
No, they're very well, like they really attend and they're really respectful of the speakers and things. We've worked with them before.
Yeah, they actually do tend to ask questions.
Yeah.
Because when you said, I don't know if you want them, it made it sound as though like, it's kind of a wild bunch. And
Oh, no. Just
they're a good
to
group.
go from 20 people to get an extra, like last time we had like those extra 20 family medicine residents and we didn't know anybody's names and it was like, oh my God, there's people everywhere. So to get 30 extra.
Yeah, if they get something out of it and they learn about this addiction, it's anybody who comes in any kind of training, it would be good because this is also a social stigma around the addiction medicine, that we have it in a professional level, in the layman kind of the level everywhere. So it would be good to know that and learn from this echo at least, that addiction exists and it's a disease and required to be treated. Even if those few things that is getting out of this echo, I think would be good for anybody to participate. So yeah, I'm all for the numbers if they get more, but I think that the introduction would be a little bit lengthy if we go to the same way that we go right now.
Yeah, no, we can't do it without it.
We usually, I mean, in the past with CME, we've not really had more than 10 to 15 at any event we've ever had.
Yeah,
I mean, like 15 is kind of stretching it compared to what we usually get.
Yeah, there's just not as many opportunities right now with COVID. I feel like there's just been more at a few things that I've seen.
Okay, let's do it then. And we will work with Ernie Maupin about requiring the nurse practitioner students to have a case and cordially invite specified dates the rest of our participants.
Be great. Yeah, I'm gonna go eat something.
Yes.
Before my stomach gets
too loud.
I'll see y'all.
Thank you, everyone.
Thank you.